Now, you all know that heart failure is a multi-system disorder with very high mortality and morbidity. Morbidity in the form of recurrent hospitalization in 1 year. And this is a data from my institute, we published in ESC heart failure, which showed that 1 year hospitalization for heart failure was 69.34%, which was due to non-compliance of the drugs due to non-affordability. So such a person is standing here to argue that we should simultaneously start all these drugs, and two of which are really costly. Now, we all know that the pathophysiological or targets moved from hemodynamic subsets to neurohormonal modulation, which we block multiple pathways. And the importance of combining all these drugs which block these pathways are, there is significant difference between a patient on guideline directed medication and not on medication. This is the data from Trivandrum Heart Failure Registry, which Dr. Harikrishnan was the author of it. Now, the mortality at 1 year was 32%, very high. So, to reduce this mortality, we have multiple drugs, and as it is shown, the highest reduction is with beta blockers and ARNI. Now, we give these drugs in a sequential way. We start drugs and escalate the dose, then again start the next drug, and if we go on doing like this, it may take at least 6 months to complete this process, and this is unacceptable because this data shows that within 1 month of hospitalization with discharge itself, the mortality is very, very high. So with every passing visit, the absence of more than or equal to one therapy results in unnecessary hospitalization and death. Now, whether to wait for target doses, low doses of drugs for heart failure with reduced ejection fraction yield important benefits, and target doses are often only modestly more effective than low starting doses, as shown by the Atlas study, where if you increase the dose to 3 to 7-fold, the benefit which is obtained is just as that obtained by adding a beta blocker, ARNI or SGLT2 inhibitors. So the difference in the efficacy between an intermediate and high dose of AC inhibitor is likely to be very, very small. Now, what about the uptitration of the drugs? Now, how many of you give carvedilol 25 BD or metoprolol 100 BD for your patients with heart failure? The CBIS CLD trial showed that they could achieve only 20% of this target dose of beta blockers. Now, dose alone is not important because you know that in SHIFT trial, they added the ivabradine and reduced the heart rate below 75, and there was significant mortality benefit. So it is not alone the dose alone that matters. And many of these drugs exert effect quite early after initiation, as shown by Dr. Harikrishnan. This is data from Copernicus trial, which shows that the curves diverge as early as 14 days. Now, the SOLD trial, there is an older data. Again, the benefit of enalapril is obvious within 2 weeks. The Emperor reduced trial, again, benefit as early as 30 days. And you know the Ephesus trial, and this is the heading of the Ephesus trial, eplerenone reduced mortality 30 days after randomization. Okay, so all these drugs reduce mortality as early as 2 to 4 weeks. So this is the importance of my argument that these drugs must be started as early as possible. So adding drugs means adding life to the patient. And if you give 4 drugs, the mortality benefit will be much more than obtained with 3 or 2 drugs. Now, this graph shows that the mortality benefit with the foundational therapy is much more than that is obtained with a 2-drug therapy or a 3-drug therapy. And this is what Dr. Harikrishnan alluded to, that is the drug treatment. We have to concentrate on the Fantastic Four, which is ARNI, MRA, beta blockers and SGLT2 inhibitors. Why ARNI? There is paramount evidence supporting this paragon molecule, leading a paradigm shift in the management of heart failure, as evidenced by a 20% more reduction in the mortality compared with AC inhibitors or ARBs. Now, the paradigm heart failure study showed that the RNA is superior to AC inhibition alone in reducing the risk of death and hospitalization. So, this review article, a network meta-analysis which came in Circulation Heart Failure in 2007, they mentioned that the combination of these three drugs, RNA beta blockers and MRI resulted in greatest mortality reduction ever. So, early switching of an ACE or ARB to an RNA might facilitate subsequent introduction of the drugs like MRA because of lower attendant risk of hyperkalemia, and this was published in JAMA. Now, how early to start RNA in acute decompensated heart failure? The data is from Pioneer Heart Failure. Benefit we got as early as 1 week after initiation. Again, in DAPA heart failure, Dr. Harikrishnan told, regardless of the presence or absence of diabetes, we have benefit. The DAPA HF trial and Emperor reduced trial showed that the treatment effect emerged quickly within the first few weeks itself. And this is the Soloist trial by Dr. Deepak L. Bhatt, which showed that the benefit is obtained as early as 28 days. So, can we use SGLT2 inhibitors earlier in the therapeutic pathways even before RNA and MRA? Yes, again, the data is from DAPA, the study on dapagliflozin, which showed that it exerts benefit irrespective of whether the patient is on RNA or not. Now, will background therapy affect the benefit of SGLT2 inhibitors was again answered by this meta-analysis of Emperor reduced as well as DAPA HF trial. Now, coming to other issue of heart failure is the sudden death. Now, this is one trial, CBIS-3 trial, which tested the two strategies, that is beta blocker first versus enalapril first, and there was a 46% reduction in the incidence of sudden cardiac death. So, with this evidence, why can't we move from the conventional sequencing to rapid sequencing? Now, the practice issue is that even in Europe, only 40% of patients receive MRA. So, we have a reluctance to add drugs. Now, you all might have read this landmark article which came in Lancet, which is a combined data of the three trials, Emphasis, Paradigm and DAPA heart failure trial. And they showed that if you use all these drugs together, the benefit is much more than obtained with one or two drugs. And with this actuarial method and the projected survival benefit, they showed that if you switch from AC inhibitor to RNA, you get 6.3 additional years of survival for a 55-year-old person. But there is a gap between a theoretical patient and a patient of years. So in my hospital, AC inhibitor, beta blocker, aldosterone inhibitor is free of cost, but I can't imagine starting RNA and SGLT2 inhibitors to a patient who is coming to a general government hospital. Now, you may think that these authors have some vested interest, the trial leaders spend less time with patients and more time with laptops, but whatever be, if you believe at least 50% of data which I have shown, I have every reason to tell you that you have to start these drugs quickly. Now, if you treat a STEMI, you have no reluctance in prescribing DAPT, statin, AC inhibitor, MRA. Now, why not in heart failure? Because now, if you take a STEMI with diabetes, the mortality is around 12%, whereas the heart failure mortality in Trivandrum registry is 32%. So, why don't you treat heart failure aggressively? And you may ask me, any guidelines endorse this view? Yes, the Canadian guidelines endorse. You can see on the top, they ask you to start all the 4 drugs simultaneously, and the scope for a polypill may reduce the cost. So, I am strongly in favor of adding these 4 pillars of heart failure as early as possible, but no two patients are similar. So, one patient may be having a heart rate of 50, another may be having 110, one may be in AF, other may be in sinus rhythm. So, you have to individualize this treatment, and you can review this slide later. So, I will initiate the treatment with all these 4 drugs, at least an AC inhibitor, ARB, beta blocker, MRA, and SGLT2 inhibitors, then I will definitely titrate to maximum tolerated dose and escalate the other drugs like hydrolyzine isosorbide dinitrate I use, ivabradine I use, and digitalis I use occasionally, but I don't have an experience with vericiguat. Thank you.